I'm Dr. Ralph Abraham, consultant in diabetes at the London Diabetes Centre. And today, I'd like to talk to you about the variabilities of insulin action in patients who need to take insulin for their diabetes. Much of my time in consultations with patients is involved with assessing their glucose control when they're taking insulin injections and helping them improve it. I have patients who have absolutely immaculate blood glucose profiles, so much so that one would question whether you could detect that they actually have diabetes. And they are people who take multiple insulin injections every day. And yet, the great majority of people who use insulin have great difficulty. And despite many of them being very experienced and putting a lot of effort and knowledge and education programs in their practice, they still show widely varying glucose excursions, particularly after food, but also when they're asleep. So if you inject the same dose of insulin into your skin in exactly the same way, in a fresh site every day, you would expect to get an identical glucose response, but you don't. And they're often wildly different. So I'm going to show you a trace from a patient, and this is the sort of thing that we regularly see, and I hope you can see this in front of you now. These are 4 days of a patient who takes the same amount of long-acting insulin every night before she goes to bed at about 11 o'clock. And you can see that on Thursday, it's almost as though that insulin didn't work because her blood sugar is rising. On Wednesday, she seems to have a very good response, and it's coming down so that she has a normal blood sugar by 4 o'clock in the morning. On Tuesday, again, it seems that her insulin doesn't seem to work at all. And on Monday, it seems she started off low and stayed normal, which is probably what you would expect a long-acting insulin to do. So this video today is going to take you through the possible reasons for this. And I think it's important that every patient begins to understand why it can be more complex than perhaps your healthcare professional makes you believe. First of all, it's important to emphasize that once you've passed your first grade with basic education, you will learn that the response of your blood glucose to insulin and the level of your blood glucose is not only related to food and your insulin dose. It's much more complicated than that, and I want to discuss the various reasons why glucose control can be effortlessly achieved if you're an intensive care patient in hospital, getting your insulin through your vein, not eating normal food and being passive and lying in the bed and not doing anything. The moment you have normal living and you're taking subcutaneous injections and eating food, all hell breaks loose. So the same dose of subcutaneous injected insulin can have different blood glucose lowering effects in different patients. The scientists will call it between patient variability. If you take the same insulin, inject it into different people, you'll get completely different responses. Everyone's not the same. Insulin resistance varies with different patients. It'll vary with the amount of fat you have on your abdomen, the amount of exercise you do, with your body weight, with your genes, with your stress levels. And insulin resistance is very well studied and understood in type 2 diabetes. And so we know that there are genetic, weight, stress, and activity factors, all of which play an important part. However, in day-to-day life in one patient, that's you, this is unlikely to be a major factor in long-term control, as you're the same every day. And most of the factors that impact on an individual patient's response to glucose do not change much from day to day. So while between patient variability might be of great importance to a pharmaceutical company, it's less relevant to you as the patient. Now, this is not the case within patient variability, because the blood glucose response to the same insulin dose injected on different occasions can be different. And some of the factors involve the type of insulin you use, the injection site, the technique, the temperature, the exercise level concomitantly, stress levels concomitantly, whether the correct dose is used every time, and the time that the dose is given. So it's not straightforward or simple. Let's start with the type of insulin. Once insulin is injected into the skin, unlike what happens when it's injected into a vein directly into your blood, it congregates into groups of 6 molecules called hexamers. And these are not active when they're clumped together in groups of 6. They have to dissociate in the skin into single molecules before they can be absorbed and become biologically active. This actually slows down the action of insulin in the skin. And the speed at which this dissociation happens is influenced by heat and blood flow. So there's a world of difference between sitting on a beach in the Caribbean and skiing on the mat, in the Alps in the middle of winter. Your absorption is going to be several orders of magnitude different. Blood flow also influences insulin absorption. If blood flow is stimulated by exercise, then you're going to get faster insulin absorption. Actually preventing the dissociation of hexamers, or even preventing the formation of hexamers, is an avenue of approach pharmaceutical companies are using in order to change the absorption characteristics of insulin. So there is variability in absorption. And what is not widely appreciated is exactly how big this is. It can be up to 25% within patients, and actually as much as 50% between patients. Well, that's enormous, that's huge. The variability is higher for some insulins, and over the last 30 or 40 years, insulin manufacturers have improved the characteristics of insulin so that this between patient variability is not so extensive. Older isophane insulins and lente insulins, which some of you may remember, were very variable. But even soluble insulins and modern insulins vary between 21 and 44% between patients, and 13 to 20% within a single patient. The best long-acting insulin currently is Detamir, which is better than glargine and which is better than the older isophane insulins. But of course, with this improved reliability comes a shorter duration of action. And there's variability in the action of these insulins, which vary according to injection technique, the angle at which the needle goes into the skin, varying rates of food absorption, which vary from one person to another, and which vary between different types of food. What are the factors that influence the action of insulin in the skin? Well, one of the most important is insulin sensitivity. When I said that we're all very variable in our response, one of the reasons is the varying degrees of insulin resistance. That means the varying ways in which a person responds to a given dose of insulin. The most powerful is the level of underlying insulin resistance, or its converse, insulin sensitivity. This is affected by time of day, by concomitant hormone levels, by your weight, by exercise levels. Hormone levels, well, cortisol and adrenaline are stress hormones. They go up if you're ill. So when you're ill, you need more insulin than when you're not ill. When you're stressed, you need more insulin than when you're not stressed. And at the time of the menses and after the menopause, women's female hormone levels are at their lowest. And therefore, there's a huge difference between insulin requirements in the middle of a menstrual cycle and at the end. Insulin absorption itself is influenced by patient-related factors and the properties of the insulin you use. So the patient-related factors are where you inject. Most patients, taught a long time ago, will do their insulin injection in a parallel, you've got to see my arm here, of their arm. I'll get the screen so that you can see what happens when my arm, which is here, is put into, say, my tummy or into my leg. And the radius of the arm determines where the insulin injection goes, because it's most convenient. But the result of that is that the person puts the injection into the same spot every time. And if you've done that for 30 years, you'll find your skin is hard and fibrosed, and insulin doesn't get absorbed from there. So you've got to use fresh sites of injection. Your depth of injection is important, although much less important now that we have 4 millimeter and even most people will use 5 millimeter needles. So your injection is nearly always into subcutaneous tissue. But if it is into muscle because you have no subcutaneous tissue, or very thin, then of course the insulin is absorbed much faster. Ambient temperature is very, very important. As I've explained, if you live in a hot tropical country, absorption is much faster than it is perhaps in a temperate country. And so when I have patients who show me differing responses to insulin when they come from back home, which is a hot tropical country, and then they show me what's happening to them in London, you've got to understand that ambient temperature plays a big role. Massage, lots of patients have massage. Orthostatic movement, whether you're upright, whether you're lying down, all influence absorption and dispersion of the insulin from its depot where it has been injected. A long time ago, we used to have types of insulin that required shaking and mixing properly. This was never or rarely done properly by patients. And fortunately, this is not a problem we have much at the moment, in the current day. Even the introduction of pens took away a huge error in dosing, which used to occur with syringes. If people used to have to take small amounts of insulin and they had a cataract, they could never be sure that their insulin dose from time to time wouldn't vary by 100 or 200 or 300%. And I do hope that with voice memos, with control with smartphones, that even if people were poorly sighted, they could guarantee that with modern technology, dosing would be accurate, and we would never have to worry about the fact that somebody thought they were taking 6 units of insulin, but might have been taking anything between 2 and 20 units of insulin. So once you've got rid of the bubbles, once you're sure that you know that the right amount of insulin is being taken, once you know that you need a fresh site and temperatures controlled, do you still get errors? And yes, you do. And these errors really are probably not controlled. And it's very important that patients realize that maybe they shouldn't seek for nirvana, because technically, once you inject into the skin, you introduce error. And if you're going to avoid that error, you actually have to change where insulin is injected and how it's injected. So does any of this matter, or is this just another search for perfection from your diabetes doctor? Well, I'm afraid it does matter. There's been a lot of research into the differences between populations that have great variability in their glucose excursions. You know, their glucose ups and downs look like the Himalayas. And comparing them with patients who are very obsessive about their diabetes and have virtually flat glucose profiles. Variability in science is often assessed as a coefficient of variation. And if you take the fasting glucose, so you're taking out of the equation differing amounts of food taken by patients, then there's lots of evidence that mortality statistics are much less in patients whose fasting glucose is less variable. So it clearly matters to be able to get less variability in your glucose responses. The best way of doing that is going to be with continuous insulin infusions and a closed loop solution. That means wearing a sensor and a pump all the time, and that's the way modern diabetes is going. But for those of you who don't want to change, who cannot change, unable to change, it's important that you understand how complex glucose responses to an insulin injections are, and how injections into the skin are a poor approximation to what happens in a normal person whose insulin is secreted from the pancreas, goes directly to the liver in the bloodstream, and doesn't have any of the problems that people who do injections of insulin have. So don't be too hard on yourself. Understand that you can do lots to help yourself, but lots also comes down to the method and way in which insulin is injected into the skin. So thank you for listening to me. It's Dr. Ralph Abraham here.